Spinal cord injury, or SCI, refers to damage to the spinal cord, vertebral column, supporting soft tissue, or intervertebral discs caused by trauma. In the U.S., around 294,000 people live with SCI, with about 17,810 new cases yearly. The most common causes are motor vehicle crashes, falls, violence, especially gunshot wounds, and sports injuries. Males make up about 78% of SCI cases, and the average age at injury is 43 years. Risk factors include being young, male, and using alcohol or illicit drugs. These factors highlight the importance of prevention. Life expectancy has improved with better health care, but remains lower than for the general population. Major causes of death include pneumonia, pulmonary embolism, and sepsis. Paralysis can occur below the injury level. Paraplegia, paralysis of the lower body. Tetraplegia, paralysis of all four limbs, formerly called quadriplegia. The most frequent injury is incomplete tetraplegia, followed by complete paraplegia, complete tetraplegia, and incomplete paraplegia. Pathophysiology. CI damage can range from transient concussion, full recovery possible, contusion, laceration, or compression, complete transection severing, which causes paralysis below the injury, most often affected C5, C7, T12, and L1 because these areas have the most mobility. SCI is classified into primary injury, damage at the time of trauma, usually permanent. Secondary injury, processes like edema and hemorrhage that worsen damage. Preventing secondary injury is a major focus of acute care. Veterans considerations. Veterans represent a large portion of SCI patients. Compared to civilians, veterans are often older, male, and may have war-related SCIs caused by gunshot or explosion injuries. Veterans often face unique challenges like PTSD, adjusting to civilian life, and loss of military identity. These factors can increase risk for poor health behaviors and mental health problems. On the positive side, veterans often show stronger social support, better independence, and higher integration into society compared to civilians. Clinical manifestations. The effects depend on injury type, extent of cord damage, and level, location. Complete lesions. Total loss of sensory and voluntary motor function below injury. Incomplete lesions. Some sensory or motor function remains. Injuries may be classified by area of cord damage: central, anterior, lateral, Brown-Séquard, or peripheral. Effects of CI syndromes. Central cord syndrome. Motor deficits greater in upper than lower extremities. Variable sensory loss, bowel bladder dysfunction variable, usually caused by cervical hyperextension. Anterior cord syndrome, loss of pain, temperature, and motor function below lesion. Light touch, position, vibration remain intact, often caused by acute disc herniation, hyperflexion, or anterior spinal artery injury. Lateral cord syndrome, Brown-Séquard syndrome, ipsilateral paralysis and loss of touch, vibration, pressure. Contralateral loss of pain and temperature, usually caused by knife missile injury, unilateral fracture dislocation, or ruptured disc. Classification: Asia. The American Spinal Injury Association, ASIA. Classification assesses the degree of motor and sensory function. Neurologic level, the lowest level where sensory and motor functions are intact. Below this level, deficits may include paralysis, bladder bowel loss, loss of sweating, vasomotor tone, and hypotension. If conscious, patients often report severe back or neck pain, but absence of pain does not rule out CI. Respiratory dysfunction depends on level. C4 or above, paralysis of diaphragm, usually ventilator dependent. T12 or above impacts respiratory function. Diaphragm C4, intercostals T1, T6, and abdominals T6, T12 are critical. Assessment and diagnostics, full neurologic exam. Initial imaging, X-rays, especially lateral cervical, CT scan. MRI if ligament injury suspected. If MRI contraindicated, myelogram may be used. Assess for other injuries, often head and chest. Continuous ECG monitoring due to risk for bradycardia or asystole. Emergency management SCI is always suspected in trauma patients until ruled out. Initial management includes rapid assessment, immobilization on spinal board, head and neck in neutral position. One team member stabilizes head to prevent flexion, extension, or rotation. Patient carefully slid onto board with at least 4 people. Spinal injury patients kept supine, never twisted or allowed to sit up. Immediate transfer to trauma center with SCI expertise. If bone instability is excluded, patient may later be moved to a standard bed or collar removed. Functional abilities by level of injury, Table 63-3. C1, C3, little no control, usually ventilator-dependent, electric wheelchair with sip and puff. C4, diaphragm moves, dependent but may eat with adaptive devices. C5, shoulder strength, elbow flexion, modified independence with wheelchair. C6, C8, wrist and finger function, more independence with transfers and manual wheelchair. T1, T12, trunk and abdominal control, independent with wheelchair. L1 to S5, progressive return of leg and foot control, ambulation possible with assistance or independently depending on level. Medical management acute phase. Goals: prevent secondary injury, observe for worsening deficits, and prevent complications. Pharmacologic therapy, high-dose corticosteroids once used, but now controversial and not standard of care. Respiratory therapy, oxygen, avoid neck movement during intubation, diaphragmatic pacing trials for high cervical injury. Skeletal traction reduction, skeletal tongues or halo device for cervical alignment, surgical stabilization often needed for thoracic lumbar. Halo device provides immobilization while allowing ambulation. Quality and safety alert. Vital functions supported until spinal neurogenic shock resolves. Can take months. Surgical management indications. Cord compression. Fragmented or unstable vertebra. Penetrating cord injury. Bony fragments in canal. Worsening neurologic status. Goal: preserve function, relieve pressure, and stabilize spine. Acute complications. Spinal shock. Loss of reflexes below injury, flaccid paralysis, areflexia, loss of bladder bowel reflexes, usually temporary. Neurogenic shock, loss of autonomic function, hypotension, bradycardia, cardiac output decrease, inability to sweat, risk of fever. Respiratory failure, especially with cervical upper thoracic injuries. Venous thromboembolism, VTE, high risk due to immobility. Prophylaxis includes anticoagulants, compression devices, and sometimes vena cava filters. Breathing pattern, cough strength, lung sounds. Monitor motor and sensory function closely. Use flow sheets to track changes. Test motor ability, hand squeeze, finger spread, toe and foot movement. Test sensation, light touch or pinching, eyes closed. Assess for spinal shock, loss of reflexes, bladder distension, atonic bowel. Palpate bladder, check for paralytic ileus. Monitor temperature. Patients may have impaired ability to regulate body temperature. Diagnosis. Common nursing diagnoses. Impaired breathing and impaired airway clearance. Impaired mobility, risk for injury, impaired skin integrity. Urinary retention, constipation. Acute pain. Autonomic dysreflexia. Collaborative problems, potential complications, VTE. Orthostatic hypotension. Goals: improve breathing airway clearance, improve mobility, prevent injury, preserve skin integrity, relieve bladder retention and constipation, reduce pain, recognize and manage autonomic dysreflexia, prevent complications. Nursing interventions for acute SCI. Promoting breathing and airway clearance, monitor vital capacity, O2 saturation, ABGs. Clear secretions, suction carefully, chest physiotherapy, assisted coughing, breathing exercises to strengthen diaphragm, hydration, humidification to prevent thick secretions. Watch for respiratory infections. Improving mobility. Maintain body alignment, avoid turning until cleared. Splints for foot drop, removed and reapplied Q2H. Trochanter rolls for hip rotation. Passive range of motion 4 to 5 times daily. Watch for hypotension with position changes. Gradually increase mobility when spine stabilized. Preventing injury from sensory alterations. Stimulate intact senses, touch, sound, food, conversation. Glasses, hearing aids, music. Provide emotional support. Maintaining skin integrity. Change position at least Q2H. Inspect skin regularly, especially pressure points. Keep skin clean, dry, use lotion. Teach patient family about skin care. Maintaining urinary elimination. Bladder is a tonic initially, urinary retention. Use catheter short-term, then intermittent catheterization. Educate family and patient about monitoring urine, fluid intake, residuals, and infection signs. Men, external catheters and leg bags may be used. Improving bowel function. Paralytic ileus is common initially, NG tube may be required. Begin bowel program once nutrition resumes. Use stool softeners, laxatives, rectal stimulation as needed. Comfort with traction devices, halo, tongs. Inspect pin sites daily for redness or drainage. Clean pin sites. Inspect skin under vest for redness, blisters. Teach patient and family about care. Recognizing autonomic dysreflexia occurs after spinal shock resolves in lesions above T6. Symptoms: pounding headache, hypertension, diaphoresis above lesion, bradycardia, nasal congestion. Causes: bladder distension, most common, bowel impaction, skin irritation. Management: sit patient upright immediately. Identify and remove trigger: empty bladder, remove fecal impaction with anesthetic, remove irritants. If unresolved, IV antihypertensives. Clearly label patient's chart for risk. Educate patient and family. Managing complications. Monitor for VTE, DVPE. Start anticoagulation early. Prevent orthostatic hypotension with compression stockings, abdominal binders, and gradual position changes. Promoting home and community care. Education begins early and continues long-term. Focus on mobility, bladder, bowel, skin care, recognizing complications. Emphasize coping strategies and support systems. Peer mentors and support groups improve adaptation. Evaluation. Patient demonstrates improved breathing, mobility, skin care, bladder, bowel function. Recognizes and manages autonomic dysreflexia. Avoids complications, VTE, infection. Tadashtar, long-term management of SCI medical management. Patients need lifelong follow-up in SCI clinics. Long-term complications. Disuse syndrome, bladder kidney infections, spasticity, depression, heterotopic ossification, bone overgrowth, pressure injuries. Focus on prevention, early detection, and management. Nursing process. The patient with tetraplegia or paraplegia assessment. General condition, complications, coping. Inspect skin carefully. Review bowel and bladder programs. Assess motor sensory deficits, vasomotor control, sexual function. Monitor emotional psychological state. Patients often cycle through grief stages: denial, anger, depression, acceptance. Diagnosis: impaired mobility, risk for disuse syndrome, impaired skin integrity, urinary retention, constipation, impaired sexual function, ineffective coping, knowledge deficit about long-term management. Complications: spasticity, infection, sepsis. Goals: mobility, skin integrity, bowel bladder control, sexual expression, coping, knowledge, no complications. Nursing interventions for tetraplegia, paraplegia. Increasing mobility. Exercise programs to strengthen upper body and unaffected muscles. Use push-ups, sit-ups, rubber ball squeezes, weights. Mobilization with braces, crutches/wheelchairs as appropriate. Stress importance of cardiovascular fitness. Nutrition counseling to prevent obesity and related conditions. Preventing disuse syndrome. Passive range of motion at least 4 eyes daily. Frequent repositioning and stretching to prevent contractures and foot drop. Promoting skin integrity. Teach patients to inspect their skin, use mirrors. Turn every 2 hours in bed. Relieve wheelchair pressure by push-ups or leaning. Prescribe cushions and adaptive equipment. High protein, high calorie, high vitamin diet. Improving bladder management. Encourage hydration, about 2.5 liters per day. Prevent infection with frequent emptying, hygiene, proper catheter care. Teach signs of UTI. Women may need pads, undergarments, or diversion procedures. Establishing bowel control. Reflex training with digital stimulation if appropriate. Regular schedule, usually every 48 hours. Adequate fiber and fluids. Counseling on sexual expression. Many can have fulfilling relationships with modifications. Men may use prostheses or erectile dysfunction meds, sildenafil, tadalafil. Education on birth control. Watch for VTE risks. Sexual counseling provided in rehab centers. Enhancing coping. Depression and grief are common. Encourage independence. Avoid fostering dependence. Family counseling often needed. Support groups and therapy useful. Managing spasticity. Can interfere with ADLs, but sometimes helpful for tone. Usually develops weeks, months after injury. Medications: baclofen, botulinum toxin, diazepam, dantrolene, tizanidine. Adjuncts: clonidine, passive ROM, frequent turning. Managing infection and sepsis. UTIs, respiratory infections, and skin infections common. Prevent with hydration, aseptic catheter care, turning schedules, chest physiotherapy, nutrition. Aggressive early treatment with antibiotics and supportive care. Transitional and community care. Education on skin care, catheter and bowel programs, exercises, and complication recognition. Home visits for safety, equipment, and reinforcement of education. Assess coping strategies. Address substance use if present. Promote peer mentoring and support. Vocational rehabilitation for job education placement. Ongoing follow-up with healthcare team for life. Evaluation. Long-term, patient achieves maximum mobility, intact skin, bowel, and bladder control. Reports sexual satisfaction and improved coping. Demonstrates knowledge of long-term management. Remains free of complications.